Good morning. We are having the remaining part of benign based disease discussion today. We have three presenters and Professor Shobita Chatterjee, who is Professor of Surgery at IPGM SSKM Hospital, will moderate the session. The first presenter was Dr. Malavika, but she has some hospital emergency. So her presentation will be shared by Dr. Milit. So this will be a discussion on ANDI, okay, clinical presentation and management. So I believe you can share the screen and start.
Good morning, ma'am. Ma'am, are the slides visible?
Yes, Milit, they're visible. You can start.
Thank you, ma'am. Aberrations in normal development and involution. The normal development of the breast. The normal development of the breast is under hormonal influence, mainly under multiple hormones such as estrogen, progesterone, FSH, LH, prolactin, oxytocin, thyroid, cortisol, and growth hormone. Now, the different hormones that that have the role of the development of the different components, such as estrogen is responsible for the ductal development, progesterone for the epithelial and lobular development, prolactin for lactogenesis, and FSH, LH, and GnRH for the development, function, and maintenance of the breast tissue. Now, the hormones are related to the menstrual cycle, as this is due to the changing levels of the estrogen and the progesterone. Menarche, it causes initial breast engorgement and epithelial proliferation during menarche, and during menopause, it initiates the involution of the ducts and the alveoli. Now, aberration in normal development and involution, or the term ANDI, it is the benign breast diseases that are related to normal development and involution of the breast. Now, these are a spectrum of conditions that range from normal phenomenon to diseases. Now, this is the classification of benign breast disorders, the ANDI classification of benign breast disorders. And as we can see, in different reproductive years, there are some normal events that take place, and the subsequent disorders and diseases that might take place related to them. For example, in the early reproductive years, the lobular development, if it is aberrant, it might lead to a fibroadenoma or a giant fibroadenoma. And nipple eversion is the normal event that there might be nipple inversion or subareolar abscess. Now, similarly, in the late reproductive years, we have cyclical changes of menstruation, and in this case, the disorder would be a cyclical mastalgia, whereas a disease would be an incapacitating mastalgia. At the involution stage, we have duct involution, where duct dilatation and sclerosis are the normal processes. Now, in case of disorders, we might have duct ectasia or nipple retraction, and this might lead to periductal disease such as periductal mastitis. Now, broadly classifying benign breast disorders, they can be non-proliferative disorders of the breast, proliferative breast disorders without atypia, and atypical proliferative lesions. And these have been taken separately by the presenter. Now, first of all, we have non-proliferative disease. These encompass 70% of benign breast diseases, and they carry no risk for breast cancer. First is fibroadenoma, usually seen in ages 15 to 25 years. This is an aberration of lobular development. Now, more than 3 centimeters is known as a giant fibroadenoma, and multiple fibroadenomas are when there are more than 5 lesions in one breast. They show hormonal dependence similar to that of normal breast lobules during lactation and during pregnancy, and they involute in the post-menopausal period. They can be subclassified into tubular and lactating adenomas. The histology is that there is abundant stroma with normal cellular elements. The presentation can be asymptomatic, painless, firm, freely mobile swelling, which is why it is sometimes known as the breast mouse. They can be single or multiple, and there can be giant fibroadenoma, multiple fibroadenoma. But a giant fibroadenoma or multiple fibroadenomas are considered a disease. Now, the treatment is firstly observation, especially if it is a small fibroadenoma. They mostly involute in postmenopausal period, hence they may be monitored with sonomammography, cryoablation, vacuum-assisted biopsy, and surgery. Now, surgery, the indications for surgery include multiple fibroadenomas, giant fibroadenomas, if the patient wants a surgery because of cosmesis, recurrence, and complex fibroadenomas. Next, we have calcifications. Calcifications can be macro or micro. Macro calcifications can be a result of trauma, inflammation, and cellular secretions, and they are normal. Microcalcifications are associated with breast cancers. Now, these are less than 5 mm in size, fine linear calcifications that may show branching. The third non-proliferative disease is fibrocystic disease or fibrocystic adenosis. These are involutional aberrations. There is rapid involution of stroma causing microcysts, which causes microcysts to become macrocysts. Macrocysts, they're also known as blue dome cyst of bloodgood. Clinical features include they are tender, transilluminant, and fluctuant, can be single and multiple, and they are associated with cyclical mastalgia. Now, the management of cysts, USG guided aspiration can be done if the residual mass is palpable, FNSC or core biopsy, and a cystopneumogram is when you inject air into the cyst in order to assess the walls on mammography for any irregularity. Next, we have periductal mastitis and duct ectasia. These are assumed to be complementary processes. Duct ectasia is dilatation of the ducts leading to thick greenish nipple discharge, and periductal mastitis causes fibrosis later. It is due to repeated inflammation. Nipple inversion present since childhood due to developmental aberration in the major ducts. It causes recurrent stasis or flow, stasis to the flow, and therefore repeated bouts of infection and inflammation. And it can lead to subareolar abscesses and ductal fistula. Next, we come to proliferative disorders without atypia. Now, these disorders, in this case, the tissue, there is proliferative tissue, but they are not associated with malignancy. So, the first is sclerosing adenosis. This is mostly seen in childbearing and perimenopausal years, characterized by both proliferative and involutional changes, and clinically it may present as a breast lump, mastalgia, or as distortion of the breast, and they are associated with benign calcifications. Complex type of sclerosing adenosis may show papilloma and epithelial hypoplasia. They mimic carcinoma, and hence a core biopsy may be required. Management is mainly that we have to rule out carcinoma through core biopsy, wedge biopsy, and vacuum-assisted biopsy. Next, we have introductory papilloma. These arise in major ducts of premenopausal women. Ductal hypoplasia, they show no increased risk of cancer unless associated with atypia. Multiple intraductal papillomas are susceptible to malignant transformation, and the size range is 0.5 to 5 centimeters. They usually attached to the wall by a stalk. Grossly, in the gross specimen, they can be pink tan with it is a pedunculated growth, and they are associated with nipple discharge, which can be serous or bloody. Now, the treatment is micrododectomy. Involved duct is probed and opened up. Papilloma is excised using a tennis racket shaped incision. Finally, we have atypical proliferative diseases. Now, they include atypical lobular hypoplasia, atypical ductal hypoplasia, and lobular carcinoma in situ. Now, here we have now we have seen a number of diseases that we have just discussed, and as we have seen, most of them, a lot of them are not increased, not associated with any risk, increased risk of carcinoma. So, such as sclerosing adenosis, introductal papilloma, they do not have any increased risk for carcinoma of the breast. But atypical lobular hypoplasia, atypical ductal hypoplasia have a 4-fold risk, and lobular carcinoma in situ and ductal DCIS have a 10-fold risk. Now, normal hypoplasia, usually 3 to 5 layers, it extends to normally up to 3 to 5 layers above the basement membrane. But in case of florid hypoplasia, we have more than 70% of the lumen of the duct is occluded. Now, atypical ductal hypoplasia is lesions that has some but not all characteristics of DCIS and has all the characters, and it is DCI, or it has the characters of DCIS but is less than 2 mm in size. And atypical lobular hypoplasia is it has all the characteristics with only half of one lobular unit is involved, associated with increased cancer risk, and it's a multicentric disease. Thank you.
Thank you, Milind. It takes a lot of courage to present somebody else's presentation. Sir, do we take the questions now, or
yeah, we can finish up.
Okay. So, ANDI is something you will face, you will get in your OPD, your clinical presentation very frequently. In fact, we get more ANDI patients in our OPD than we get breast cancer patients for that matter. So it is a very important topic. And the crux of the thing is that it is a spectrum of disease. It's not a single disease, it's a spectrum of disease. So you have to know both ends of the spectrum. When you can leave it alone, just by counseling the patient, when you need some amount of management, and when you need a bit more aggressive management. There was one statement that was made in the presentation which I have a doubt about. It's about the definition of a giant fibroadenoma. Here they've said it's over 3 centimeter is a giant
5 centimeter.
Yes, it is much more. Over 3 centimeter is the indication when you can go in for a surgical excision. Smaller than 3 centimeter, you can refrain from surgical excision unless the patient is very concerned, unless it is affecting cosmesis, and unless by USG it is a complex fibroadenoma with solid and some cystic component. But otherwise, you would say a giant to be more than 5, and in some definitions, actually, they call it more than 10 as well. Okay, so that is one thing. Second thing about calcifications, this is something again we have to be very concerned about, because a single calcification is a different thing. The moment you have cluster calcifications or calcifications with spicules, okay, that is when the suspicion of malignancy comes in. So if you do get a cluster calcification, it has to be corroborated with a good mammogram, and if necessary, you have to excise it. Though it may be very difficult excising it, what you need is a wire-guided localization before you excise it. So don't leave behind a cluster calcification. A third comment I wanted to make was about nipple inversion. The moment you get a patient of nipple inversion in your outpatient clinic, the first history that you would want to know is how long that inversion has been there. Because a recent inversion is much more serious as compared to a long-standing inversion. So I think what you wanted to cover in this presentation was a long-standing inversion. So a woman may give history that it's been there since her peripubertal times and all that. And these are usually as a sequelae of recurrent ductal ectasia, recurrent inflammation, and that inflammation followed by fibrosis and pulling back of the nipple as a consequence of that. But if a patient gives a history of a recent onset nipple inversion, that is when you have to be alert, because even though a palpable lump may not be evident right away, you have to evaluate the patient. This is usually a harbinger of an underlying lump. Sir, are we taking any questions on management now, or is it only this much that we are going to deal with?
Just we discussed this part only, ANDI. So, he said that fibroadenoma regresses in menopause, but it may not take so long time.
Right.
Some fibroid regress over months or years.
Yes.
And there are some, although it's not in the textbook, but there are some study report who is saying that some drugs are helpful for regression of fibroadenomas.
Yeah. So, see, Milind, when a patient with a very obvious fibroadenoma comes to you in your clinic, what is the the protocol of management that you're going to follow for that patient?
Usually, if we are certain that it is a fibroadenoma, first of all, we have to be sure of the diagnosis. But if we are certain it is a fibroadenoma,
how do you be very sure of the diagnosis?
Triple assessment, clinical examination.
That remains the underlying structure, whether it be a benign disease or a malignant disease. Okay, so if there is a palpable lump confirmed by your imaging, which is usually a USG in this case, because it's a disease of younger women, then yes, even if you're planning to conserve the patient, reassure the patient, you may or may not go for a core needle, but at least a basic FNA must be there to document your diagnosis so that you have a firm foundation on which you can reassure your patient. Okay, so what would you advise?
Ma'am, if it is a small fibroadenoma, usually less than 2.5 centimeters, then we would counsel the patient and for observation. And ma'am, also we start with ormeloxifene, in which what we have seen it has shown promising treatment. One of my batchmates is doing a thesis on the same, and over a period of 3 months, he has seen that it has completely reduced. So, ma'am, so that's what we usually do. And otherwise, if it's the patient wants a surgery, and usually if it's more than 3 centimeter, more than 2.5 centimeters, then we can plan.
Okay.
And elderly lady, suppose 30 plus, you have this fibroma, that is one indication for excision.
See, the first thing, whenever you're asked about the management of fibroadenoma, 1 to 10, 1 to 5 will be reassurance. Okay, so you have to reassure the patient that this is not a pre-malignant condition. The chances of it turning malignant is very, 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 very less. Okay. Secondly, do not jump immediately to orloxifene. Okay, sometimes you may not require any pharmacological therapy for that matter. When you are saying reassurance, mean not reassurance with medication. It could be just plain reassurance. Okay. Armoxicillin is good, but then you have to remember it is a hormonal preparation. So you have to be judicious in your use. You would not like to use it in, say, a 20-year-old girl, an unmarried girl. If the lady is in the active reproductive period, meaning she is planning her family, again, ormeloxifene cannot be used because it makes the menstrual cycle irregular, and there may be fertility issues when you're using hormone. It is a very good drug, yes, but before starting it, you have to counsel the patient that there may be menstrual irregularities, number one. And number two is that if she's planning a family, she has to hold on with the time, for the time being. Another thing is only after she finishes her course of medication, it takes about 6 months for her menstrual and fertility issues to get normalized. So that counseling has to be there whenever you give. Very often you find these ladies, what Sir said, if it's an elderly lady or a patient with a family history of malignancy, these are the patients who, in spite of it being a smaller lesions, you might undergo, go ahead with the surgery. The point is that the 2.5 centimeter is a very relative size, 2.53, it's usually, we put it as 3. It is again the size of the lump as compared to the breast size. So in a very voluminous breast, even a little more than 3 centimeter, we might choose to, just follow up the patient. But in a small breasted lady with a 2.5 centimeter, that might cause, distortion in appearance and all that, where you might go in for surgery. So that is another thing that you have to keep in mind. Another very, very common thing in ANDI presentations, you've covered fibrocystic disease, is that they present to you with mastalgia. That may be the distress. The lump may not be so much of a distress. So what would be your plan of management in a patient of fibrocystic disease who comes to you with mastalgia?
In case of in case of mastalgia also, mainly we first of all have to, since pain is a concerning symptom for a patient, first of all, again, reassurance, and to tell the patient that this is not something to, after we have confirmed the diagnosis, that this is not something to worry about, because related to breast, if there is pain, the patient will obviously have a fear that it might be something related to a carcinoma. So first of all, reassurance, ma'am, and then primarily, ma'am, with painkillers, go for.
Okay. See, the main thing about mastalgia is there are a few histories that you should take before you jump on the treatment. Okay. You can either have a history of cyclical mastalgia, a non-cyclical mastalgia, or a mastalgia which is actually not related to the breast, related to something else, which is mimicking a breast pain. A pain may be related to the chest wall, may be related to the underlying structures, which is mimicking a breast pain. So because your treatment in each of these arms is going to be very different. Now, cyclical mastalgia, as the name suggests, cyclical, means it is related to the hormonal cycles. So whatever medication you give has to be such that it tampers with the hormonal cycle. Now, how wise or not wise that will be, that is the point of the debate. So the thing is, whenever you have a patient of mastalgia, number one, again, she has to be evaluated thoroughly so that you're not leaving behind anything. The only the good point is that a pain in the breast is a less common feature of malignancy. It is more a common feature of the benign disease. But even then, you cannot, just take it for granted that it is benign. Reassurance is very, very important. But again, since the patient has come to you with pain, you have to do something about the pain. If it is a mild pain, just normal hot fomentation and all these often work. Breast support is a very, very important part of the whole thing, because with after childbirth, after breastfeeding, the breast tends to sag, and the tug on the Cooper's ligament also aggravates the pain. So this patient has to be counseled about proper undergarments so that the breast is supported well. Third, as far as the pharmacological interventions are concerned, there are some lifestyle modifications which are suggested, but how good they are is, again, I mean, you have people voting on either side. Some say that caffeine intake should be reduced, but again, this is open to debate. For pharmacological intervention, what you have to remember, there's a whole battery of drugs which are available, which we have used for the last 30 years, but most of their roles have now been, taken off the list. Like evening primrose oil, this was very, very commonly used. Evening primrose oil, that has now been proved to be as good as a placebo. Vitamin E, another very commonly used, but now again there is evidence to say that it is not really as effective. It is a good drug, good for everything, except it gives you glowing skin and other factors, but as far as the nostalgia is concerned, it is not very effective. Now a role of vitamin D is being evaluated. They say that usually patients with nostalgia have a reduced vitamin D level. So if the patient's symptoms are significant, you should get the vitamin D level evaluated. Drugs like the hormonal preparations like Gonablock and all that, they are off now. The side effects are far too many as compared to the benefits. Moreover, they give you hirsutism, change in voice and all that. Okay. So what we are left with now is more of NSAIDs. Again, we are not talking about oral NSAIDs. We are talking about local, topical NSAID. So if the pain is significant and if it is cyclical, the patient will be able to tell you that these are the days and the months when I develop the pain. So they can be counseled that you can use hot fermentation, you can have a good breast support. You should chart your pain, very importantly, you should chart your pain to know that, you can anticipate that this is the time that I have my pain. And a topical application of an NSAID is considered to be good enough. That should be a first line of management. For people who don't respond, ormeloxifene is a good option. Again, you have to be judicious as to which patient you're catering to. Any other options other than these? Any other options other than what I've just talking about?
Tamoxifen.
Any higher therapy that we can think about?
Tamoxifen, ma'am.
Tamoxifen, right. But what dose will you give tamoxifen? Is it the same as a cancer
No,
drug?
low dose. I'm not sure. I think 10 mg on alternate days, ma'am. I'm not sure.
Yes,
10
10
mg.
You're right. It's 10 mg on alternate days. But it is very, very important that you counsel the patient adequately, that this is not for your cancer. Even if you do a good job, the pharmacy person might tell you that you're being given a cancer drug and undo all the counseling that you have done. Okay, so yes, it is 10 mg per day. Again, it should not be a first round of modality of treatment. You have to, build up your treatment. Start with the simplest. And if you see that if you have 100 patients, most 80 to 90 will benefit with just supportive treatment and local NSAID. Some will move on to ormeloxifene, and only very few will actually go on to tamoxifen. There will be a small portion who will require surgical treatment for nostalgia. Any idea which patients are this? Any idea? Which patients are these and what sort of surgical intervention are you looking at? See, there are few where they can actually identify the very spot. It's like a pain spot, okay, very sensitive area where, they will say it's not the whole breast, I can localize it for you. So when you do an imaging and they say that you can image-guided localization of that area, number one, and number, you can have a stereotactic excision of that nodular area, which is the root of the pain. But again, this is a very small percentage of patients. But if you are building up your pain management, this will come right at the top. Right? Sir, if you would like to.
Yes, no. We pass on to the next topic. This will be another important benign breast disease, which is being a challenge in diagnosis and also management. Dr. Srija Basu, who is a third-year resident at IPGM SSK Hospital, will present management of granulomatous mastitis. Srija, you can share your screen.
Yes, sir. Good morning, everybody.
Good morning, Srija.
Okay. Is my screen visible?
Make slideshow.
Good morning. I'm presenting granulomatous mastitis. The definition is a lesion of a breast which is characterized clinically by the signs of inflammation and pathologically characterized by caseating or non-caseating granulomas. The causes are, it might be primary or idiopathic, tuberculosis or mycobacterium other than tuberculosis, sarcoidosis, Wegener's granulomatosis, diabetic mastopathy, and it's associated with collagen vascular diseases like rheumatoid arthritis. Idiopathic granulomatous mastitis is now increasing a lot because of the diagnosis. The causes, now it's a new discovery that prolactin is a cause. So it is associated with hyperprolactinemia. Prolactin by two pathways acts on the mononuclear cells as well as the granulocytes, and it has a cytokine-like effect. So it is believed that granulomatous mastitis might be caused due to a periductal leakage of the prolactin, which acts like a cytokine, causing the periductal inflammation and ultimately granuloma formation. So the clinical features, granulomatous mastitis might present like a chronic breast abscess or a non-healing breast ulcer. It might present like a lump, non-healing sinuses over the entire breast, prodha orange, even post-mastectomy scar inflammations might be seen. The diagnosis, triple assessment like any breast case, USG will show a lump or it might show subdermal edema, features of a chronic breast abscess. Biopsy, either a core or an incisional biopsy. We will find chronic inflammatory cells and granulomas. We should then send it for acid-fast bacilli and CVNAT, fungal stainings, rheumatological profile of the patient should be done, and she should be screened for diabetes mellitus. This is a picture of a HP slide which is showing the granulomas. This is again a duct which is showing a granuloma. That is the left one. The right one, you can see the inflammatory cells within the duct. The treatment, primary treatment, if it's presenting with like an acute abscess, we might require incision and drainage. Definitive treatment, it might be medical or surgical. Medical, if it's a tuberculosis, then we have to start with ATT drugs. Mycobacterium other than TB would require the clarithromycin, ofloxacin, ethambutol. Idiopathic granulomatous mastitis responds very well to steroids, and if there's associated collagen vascular disease, then we have to give appropriate therapy. For surgery, if the surgery is usually done once the medical treatments fail, we might require a wide local excision of the lump, or if it's only a sinus tract, then sinus tract excision, and if there's a huge fungating mass, we might require even simple mastectomy. This is just a clinical picture. This is the first picture is of these are tubercular mastitis, and the last pictures are post ATD drugs. So it's healed quite well. This is again IgM presenting with discharging sinuses, and that is post-steroid treatment. That's the last picture. It's healed. Thank you.
Thank you, Srija. Again, another very, very important. It's over or not over? Hello, yeah. Srija, your presentation is over, isn't it?
Yeah. Yes.
Yeah, okay. Again, granulomatous mastitis is another very important thing which we were not so aware of. Srija, could you keep your presentation on, please? Because I would like you to go back to a few slides. Can you hear me, Srija?
Yes, keep up your
presentation.
Srija, keep the presentation open for some discussion. Keep the slides.
Can you hear me, Srija? Sir, am I audible?
Yes, you are audible. Srija, keep your presentation open.
You are not audible.
Acha. Yes.
Yeah, fine. Srija, can you hear me?
Yes, ma'am. Yes.
Okay, fine. Right, yeah. See, again, granulomatous mastitis has become an entity by itself because previously this was not diagnosed so frequently. So an increased diagnosis has brought about an increase in the incidence. Now, as you first said, that this is a very important point. Can you go to your slide where you showed what could be the causes of granulomatous mastitis?
Yes, ma'am.
Yeah, okay. So as you said that it is not one entity. It is actually again a spectrum of entities, and unless you can come to the diagnosis as which of these they belong to, the treatment modality number one is going to be totally different. And the very important point is something which may be a treatment for one may actually flare up the disease in another. So if you were to identify, the commonest ones are the first two, as you said. It is an idiopathic granulomatous mastitis and a tuberculous mastitis. I mean, how would you differentiate between the two? Because the clinical presentation may be the same in both. So how would you differentiate?
The main differentiating point would be by biopsy. We'll get AFB positive in tuberculosis, plus it will show caseating granulomas, while idiopathic granulomatous mastitis is a non-caseating granuloma. So it's mainly a pathological diagnosis.
So idiopathic granulomatous mastitis will be a non-caseating granuloma, but it usually arises from the breast lobules. Okay, as opposed to that, tuberculous mastitis are the caseating or the necrotizing granulomas, and they arise, they're more centered around the ducts. So if you are looking at the pathology or the core needle report, these are the two things, caseating versus a non-caseating, arising from the ducts versus arising from the lobules. That is the first thing. Okay. Now the point is, since they present in the same way, the workup remains the same. Okay. So it is again the triple assessment. You do a clinical, you do the imaging, and you end up with doing the tissue diagnosis. Now, once you come, you said that the commonest cause is, one of the commonest is the idiopathic granulomatous mastitis. But what you said, prolactin is one of the reasons. What is the second most common for etiology of idiopathic granulomatous mastitis? Second to prolactin, hyperprolactinemia is the commonest. But what is the second most common? Autoimmunity is a very common thing. Autoimmunity, it's an autoimmune cause.
Yes.
Because that dictates whether you're going to use steroids or not. If it is hyperprolactinemia, usage of steroids should not help. But we are saying that steroids are an integral part of the management of granulomatous mastitis. So it is also considered by some to be an autoimmune disorder. But to be very honest, nobody is very clear till now as to what is the cause. These are probable things. There, in fact, you might have autoimmune, you may have just duct ictasias which have gone on to progress to granulomatous mastitis. You may have sarcoidosis, and you also have idiopathic at the end where you do not have any reason. Now, coming to the treatment, can you come back to that slide, please, of treatment? Right. So, if it comes as an abscess, you do not know whether it is granulomatous mastitis or not. Patient has come to your OPD with a breast abscess. You do an incision drainage of that abscess. Now, the patient is following up with you with a history that the abscess is not healing. So this is when very often, you become suspicious. Upfront, not routinely do we take a biopsy of the abscess cavity wall. So very often when the patient comes back to you subsequently saying that my abscess is not healing, that is when we often go back to take a biopsy of the abscess cavity. So the message is that since we are seeing an increase in the number of granulomatous mastitis cases, if we have a patient with a breast abscess, after you have drained the abscess, take a biopsy from the wall. Because that way, if you get any of the above, a caseous or a non-caseous granuloma from the biopsy, wall biopsy, you may be able to initiate the definitive treatment early as opposed to waiting for the abscess cavity to heal for a long time. Now, you've talked about the medical advices. Obviously, if you get a tuberculous mastitis, the thing is AKT. If you do not get anything, is there justification in starting antibiotics? It is a non-tuberculous. Is there justification in starting antibiotics?
Ma'am, actually, ma'am, in my OPD, we try with doxycycline. It often helps with a mycobacterium other than tuberculosis. A few patients respond really well to doxycycline. So that is something we also try sometimes. If that fails, if 14 days of doxycycline therapy fails, then we proceed for steroid therapy.
Right. So that is the point I was coming to. See, when you talked about the etiology of idiopathic granulomatous mastitis, you said that it either could be hyperprolactinemia or it could be autoimmunity. Nowhere are we saying that it could be an infective cause. So when we give an antibiotic, we give it with the notion that it is an infective cause. There are organisms, be it bacterial or otherwise, which may be leading to this. So an antibiotic is given with the aim of tackling that organism. But if it is hyperprolactinemia or autoimmune, then obviously the antibiotic should not work. It is true what you said that we initially give a trial of antibiotics. But the point to be remembered is it defies the etiological basis. If there is any associated secondary infection, yes, the antibiotic helps, but usually antibiotics do not help. And often, as you correctly said, that we do not give a usual 5-day course. We give a prolonged course of antibiotics. More so, like what would be advised is you do a core needle. While you're awaiting the result of your core needle, you start off with antibiotics. By the time you get, so the patient feels that something is being done. So by the time you get the report of your core needle, that is when you have to change tracks and move either in terms of tuberculosis or non-tuberculosis. What is the risk if you start off steroids upfront? What is the
if there's a bacterial cause, it might be there might be a flare up of the abscess itself.
Yes, absolutely. Not only if there's an abscess, it could just be a lump or it could be a sinus. Okay, so if it is particularly tuberculous, it has the diametrically opposite effect. So if you start off on steroids, you might see the disease flaring up majorly. So it is judicious not to start on steroids till you have a tissue diagnosis. That is where the role, is a supportive role of the antibiotic comes in. But otherwise, the antibiotics per se do not have much of a role. Any other medications other than antibiotics and steroids? Any other medications that you can think of?
Ma'am, specifically for if there's rheumatoid arthritis, so you treat the cause, or diabetes.
The cause, yes. Otherwise?
So otherwise, we don't really place.
We routinely do not use, but if you go through literature, if you will find that because we are saying it is an autoimmune disease, the steroid is being given with the idea that it is an autoimmune disease. So there can be other immunomodulatory drugs, like say azathioprine, or other immunosuppressant drugs like azathioprine, methotrexate. These are also drugs which can be used in the treatment of IgM. The good bit is, steroids have their own battery of side effects, and that is something which often distresses the patient, and that is why they may not be compliant with the treatment modality. So they say that if you add azathioprine or methotrexate, the dosage of the steroid can be brought down. So the battery of side effects that a patient usually suffers, that can be reduced to a certain extent. Okay. Any idea about role of local steroids? This is all systemic we are talking about.
Yes. Ma'am, I don't.
Okay. I mean, there are some studies which have said that you can do an intralesional steroid injection, obviously under image guidance. So if you have a cavity or a lump which has been proven to be idiopathic granulomatous mastitis, you can try an intralesional steroid therapy. It may require multiple sittings, but the drug used is obviously much less than the systemic type. And so again, the side effect component of the steroids is much less. But again, this is work done by certain centers. It has not yet achieved, mention in the textbooks. So this will come in as a last resort. What you have listed is fair enough. Regarding surgical excision, what are the things that you'll be worried about?
Ma'am, if we do not remove the sinus tract completely, there might be a recurrence at the first surgery site. Like it will continue, it will be continuously draining. So after year, like after we are like we should be sure that we remove the entire lump or the entire sinus, whatever we are excising.
Srija, if there is an abscess, there is no doubt you have to do a source control. You have to take out the pus. The issue becomes with a sinus tract or even a lump without an abscess. Okay. The debate is, sometimes if it is an idiopathic thing, that means an immunity related mass, that when you take out that, the healing of it may take too long. Right, in an immunosuppressed situation, the wound might not heal. So that is the debate. But yes, again, if you're doing a sinus tract excision, you have to have a very good imaging if necessary and MRI of the breast to find out, because it may not be a single sinus tract. It may be branching out. So if you take out only half of it and you leave behind half, then it doesn't help. So even if you do a sinus tract excision, you still have to compound it with the medical therapy so that if there is anything left behind, that is tackled by the pharmacological aspect of it. Large mass, whole breast, yes, in those extreme cases, you may require a simple mastectomy, but those are far and few in number. You might be knowing, because Professor Shorkar is doing a study on excision to prove that there is a leak in the duct through which the prolactin had come out and caused extraductal mastitis. Yes, it is again an experimental study. So I think you should mention it only after you have mentioned all the evidence-based things that have been in literature. These are, yes, newer developments, which probably down the line will become the modality of treatment. But as of now, I think you should stick to the algorithm that you have presented.
And another aspect of IgM is, if you give the patient steroid, most of the patient, the lump disappears. But on withdrawal of steroid, again, some patient presents with recurrence of the lump. So what should the strategy for patients who are having a recurrence of the disease on withdrawal of steroids? So yeah, steroid, lump disappeared. Again, you stop steroid, lump again reforms.
So then what we practice is we give try for 3 months. If all fails, then we go for surgery itself.
Yeah. So you can give another course of steroid or other immunomodulators as told by Dr. Chatterjee, that you can give the patient addition of methotrexate or some thiopurine. And if the patient is not responding or again relapse time again, then this is time for excision of the mass. And you should take the whole lump with the ductal and lobular unit.
Yes.
See, the point is, whenever you get a patient of a granulomatous mastitis, take the patient into confidence right at the word go. Explain that it is going to be a prolonged therapy. Nothing is going to happen after 1 or 2 weeks of medication. Be it antibiotics, be it steroids, be it surgical intervention, everything takes time. So when the word go, once you've arrived at a diagnosis, you have to tell them that it is going to be a long drawn therapy. I mean, you two have to be together through it, but at the same time, that it is not going to be life-threatening, that it is not going to, the main fear patients have is that this might also undergo malignant change. So that is something you have to counsel, but also explain that they must continue with the therapy, because we do have patients who lose to follow up midway through the therapy. So these are the patients who come back later with those multiple sinuses and fungating masses, and then you have to ultimately go on to occipital mastectomy. So the first counseling has to be that it's a long drawn out therapy and you have to stick to the therapy first.
Okay, thank you, Srija. We pass to the last topic, another important benign based disease, which now has a spectrum from benign to even malignant component, is a Phyllodes tumors in the breast. So Dr. Milind is a second year DNB PGT at MR Bangalore Hospital will deliver this presentation on management of Phyllodes tumors of the breast.
Good morning, ma'am. Good morning, respected teachers. I'll be presenting today on the topic management of Phyllodes tumor. Now, before starting the management, we'll initially talk about the various investigation modalities that are there. First of all, we have Are my slides visible? Hello, are my slides visible, ma'am?
Yes, visible.
So first of all, we have ultrasonography, or which is supplemented, can be supplemented with elastography and color Doppler. In ultrasonography, we see a well-defined capsulated and a smooth lesion. The anterior posterior diameter is usually smaller than the length. It is multilobulated. It has a heterogeneous echo pattern, and there is absence of calcification. A solid appearing mass with single or multiple cleft-like cystic spaces are seen, and it is very different to distinguish between a benign borderline or a malignant phyllodes tumor. So here, as we can see in this, this is a large lesion that exhibits irregular internal suction and a smooth outline, and it has here also a large defined oval hypoechoic lesion that is about 6 into 3 centimeters, and it has mild cystic changes. Now here we see that this is also an ultrasound, but along with that there is also an elastography image that is seen, and I would just like to compare it once with now this is an elastography image of a fibroid adenoma. So sometimes elastography and color Doppler might be used to differentiate between a phyllodes tumor and a fibroid adenoma. Next, we come to mammography. 20% of non-palpable phyllodes are picked up on mammography. In mammography, they are seen as large, rounded, oval, or lobulated. Generally, again, well circumcised with smooth margins. A radiolucent halo may be present, and calcifications, which are typically coarse and plaque-like, may be seen. So this is the image of a phyllodes tumor on mammography. These are through the various views. Finally, we have an MRI. In case of an MRI, oval, round, or lobulated masses, circumscribed margins are seen. Now, signal characteristics on different types are different. In T1, it is usually there's a higher signal intensity than normal breast. In T2, it is lower or equal. And with gadolinium, the solid component enhanced after contrast administration. And there is something called as an inhomogeneous signal, which is seen in the case of hemorrhage or cystic spaces, and this is indicative of that it's a benign lesion. So this is these are the various views in an MRI shown in an MRI. So basically, the initial workup is through mammography and ultrasound, and it is difficult to distinguish a phyllodes tumor from a fibroid adenoma. Features suggestive of phylloid tumors of a phylloid tumor is the larger size, the hypertense appearance on mammography, a heterogeneous echo, presence of cysts within the mass and internal clefts. So core needle biopsy is necessary. Now, histopathology is the cornerstone of diagnosis, and in 75% cases, it is benign. Now, for diagnosis, in case of histopathology, it is very important to examine both the epithelial and the stromal components. Characteristically, phyllodes tumor will show fibroepithelial architecture with increased intracanalicular pattern, dilated cystic spaces having leaf-like fronts protruding, which is a staghorn appearance, and hypercellularity of the stroma. So this is how a phyllodes tumor is seen under microscope. There are large blasts. There are fibroblasts and stroma growing in a leaf-like pattern. So based on the histological pattern, the WHO has classified them into benign, borderline, and malignant, and these are the various characteristics on the basis of which this differentiation is made. First of all, we see the stromal cellularity and atypia, which is the least minimal in benign and marked in malignant. Stromal overgrowth is again minimal in benign and marked in malignant. Mitosis per 10 high power fields. Less than 4 would be benign and more than 10 would be malignant. And the tumor margin, if it is a well circumscribed tumor which is not pushing into the which is just pushing into the adjacent structure, that is benign. But if it is grossly infiltrating, then it is malignant. Now there are some molecular and immunohistological features. Molecular features, no specific chromosome aberration has been noted, but on comparative genomic hybridization, we see that there are chromosomal imbalances in certain chromosomes. In high grade, in case of high grade Phyllodes tumor, there are more prominent, and in case of low grade, there are few or no alterations. Immunohistochemistry markers, again P53 and Ki67 are the most important. They are lowest, they are seen in benign cases and highest in malignant, but clinically none of them have been proven to be useful. Now next we come to the treatment. The mainstay of treatment is surgery. Now earlier there were recommendations that a wide local excision with a more than 1 centimeter margin has to be done, but now the histological type is also taken into consideration, especially in the case of benign Phyllodes tumor, where a 1 centimeter margin is no longer deemed as the standard, because nearly 87% of the patients have even with a focally positive margin show no recurrence. But the overall recurrence rate is still there's still a lot of frequent recurrence, nearly about 21%. In case of benign, it is low, 8 to 10%, and borderline of malignant, it is higher, around 13 to 18%. The initial surgical excision in case of benign or borderline would be an enucleation, whereas in case of malignant, the NCCT guideline says we go for a wide local excision with 1 centimeter margin. In case of a large malignant Phyllodes tumor, a mastectomy can be done, because they behave histologically, their behavior is histologically similar to a sarcoma. But the resection cavity, in case of an enucleation where we might have to go for a re-excision, the resection cavity must be identified, and this can be done intraoperatively, marking it with clips, or later on ultrasound. Now there are basically 3 prognostic indicators for local recurrence, but different studies have shown, but not all the studies have shown that all of them are independently prognostic. So these include the positive margin, tumor size, and mitotic activity. For benign Phyllodes tumor, if post-operatively we find that the final diagnosis of a benign Phyllodes tumor, we wait and watch. For borderline malignant, re-excision of the margins. Small tumors which are less than 5 centimeters but with high mitotic activity have a high chance of local recurrence, and therefore wide local excision with wide margin should be done. Now, in case of surgery, we have 2 options: breast conservative surgery, which is the standard of care, and especially it is appropriate if good aesthetic and oncological outcomes are feasible. In view of large size and large malignant phyllodes, we should go for mastectomy. Now, radiotherapy some studies have shown that it leads to a reduction in the local recurrence rate, especially in the case of large malignant Phyllodes tumors. But the role of adjuvant radiotherapy is controversial. They are mainly used in borderline and malignant cases, and breast conservation therapy plus radiation has seemed to have a better local control. But newer studies have shown that even though local control is better, there is no survival benefit or disease-free survival. Now, use of chemotherapy is again controversial. In case of malignant Phyllodes tumor, combinations that have been used include doxorubicin and dacarbazine. Also, cisplatin, etoposide, ifosfamide, and doxorubicin have been used. But these are considered on an individualized basis, and they are not used as a standard. Hormone therapy is also not yet a part of the management protocol. Now, finally, we have metastatic disease. It has overall poor prognosis. 22% patients with malignant Phyllodes will present with metastasis. The most common site is lung, followed by bone, heart, and liver. And especially in case of malignant Phyllodes, we must do a CT chest to rule out pulmonary metastasis. Most patients will die within 3 years, regardless of the systemic therapy. And surgical excision in this case of the breast primary shows no benefit. Thank you.
Thank you, Milind. If I could go back to your imaging slide. Right, the next one, please. The MR slide, MRI. Yeah. See, if you see the bottom middle image, this has been after gadolinium has been given. Okay, there is an enhanced, that's the one. There's an enhanced uptake, but you can appreciate the heterogeneous nature of it, this is very easily confused with a complex fibroid. Okay, so this is where the role of your core needle is very, very important. Because even a complex fibroadenoma, though we hardly ever end up with an MRI in a complex fibroadenoma, this has a similar appearance. It has a heterogeneous appearance with areas of cystic changes. So you have to be cautious about this when you go for this. Okay. You were talking about the three, whether it is benign, borderline, or moderate. That becomes the crux. Yeah, that becomes the crux of all your treatment. That becomes a crux. Even if you get it preoperatively on the basis of core needle, actually following up the biopsy later on becomes very important. Now, if you know it is benign upfront through your preoperative core needle, you had mentioned about enucleation. Is enucleation going to be adequate? Even benign phyllodes are known to recur, though the incidence is less. So what is the cause of that recurrence? What is the cause of the recurrence? It usually has, pseudopod-like things, with fingers out. So if you just do a sharp enucleation, I'm not talking about a 1 centimeter margin, but some tissue has to be left on its sides. Otherwise, the chances of recurrence becomes high. So this, obviously, if you know it is borderline or malignant, you take that precaution that you take out a 1 centimeter of healthy tissue around it. But even in benign, some tissue has to be taken even if it is a few millimeters rather than a sharp enucleation to prevent recurrence. Can you go to your treatment slide, please? Yeah, that's the one. Yeah. Now, you were talking about whether it could be either BCS or it could be a mastectomy, obviously depending on the site. Yeah. Obviously depending on the size. So what is more important? Is it just the size or the mitotic activity? If you were to make a judgment, what would be more important?
Ma'am, to mitotic activity in the sense that if it would, ma'am, we'll have to see if we are deciding for surgery, we would, mitotic activity would be more important.
Exactly. See, size is important. So, but even a small size one with a higher, we say it's up to 4 to 5 is border, 5 to 9 is borderline, over 10 is malignant. But we, as far as all practical decisions for the surgery is taken, is below 5 or above 5. If below 5, we are thinking in terms of a conservative surgery. If above 5, we are thinking in terms of a more radical surgery. I'm not talking about radicality as in malignant cancer, but it on a more radical surgery. So the mitotic index becomes the decisive factor, because even if you have a small lesion with a higher mitotic index, again, the margin is going to matter. And when you have to keep in mind the margin, even if you are offering breast conservation, you have to be very cautious that keeping the margin in mind, whether I'll be able to just get away with a type 1 oncoplasty or whether I will require my plastic surgery colleagues' help in doing a higher oncoplasty. Okay, so the mitosis is the main thing. Size does matter, but ultimately the mitotic factor is it. As far as adjuvant treatment is concerned, very honestly, hardly anybody has much in it. Chemotherapy, again, as you very correctly put, that they are all individual based, customized treatments that are offered. See, this comes, right, it's like a sarcoma. So you do not have much role of chemotherapy here. Radiation, again, the big ones which have infiltrated deep, maybe involved the pecs, maybe gone right up to the ribs. These are the patients. We had a patient who was diagnosed to have phyllodes in her 3rd trimester of pregnancy. She was referred from gynae to us. Now, because her delivery was due, we waited, we did the investigations, we waited. We waited for her to deliver and then we went ahead with the surgery. But within 3 months, she came back to us with evidence of lung mets. Because it was a very large mass, it had infiltrated the ribs and had gone beyond. So these are the ones that we have to be cautious about, because these are the ones who probably have some role of chemo or radiotherapy. Most of them do not, hormonal obviously doesn't matter. Most of them do not respond very well to either chemo or radiotherapy. Any role of auxiliary treatment?
No, ma'am, it is not indicated in case of phyllodes.
What is the reason behind not?
Ma'am, because even in metastatic disease, the route of spread is very rarely through lymphatic. So lymphatics is not usually involved.
Correct, correct. So it is more of a hematogenous spread. So you
Hematogenous
will
spread.
get it more in the lung and the liver and less so in the axillary lobe. So routinely we do not do any axillary dissection. But yes, if you are doing a mastectomy or if you're doing even a breast conservation and there is a palpable node, if preoperatively diagnosed, it is better to document. Do an FNA if necessary. If you're doing a mastectomy and the axilla is easily accessible, you don't have to take a separate incision. You might remove a few nodes if it is there. But a routine axillary dissection is not indicated in surgery for the phyllodes tumor. Sir, if you would like to...
Regarding the excision, in borderline, enucleation is not advisable. Even in borderline tumor, you have to do a clear excision. It may not be a clear one-sided margin, but it should be a complete excision. So enucleation is still a method of choice for fibroadenomas. Even when you have a imaging diagnosis of Phyllodes tumor, it is better to do a excision. Because in enucleation, the point for enucleation is even if it's a benign tumor and it recurs, you can re-excise. So it's not that it will undergo metastasis initially. So for borderline and malignant, it's an excision with 1 centimeter margin. For benign, you can opt for just a complete extracapsular excision or a enucleation.
So the term extracapsular is very important. See, do not leave behind anything, because even a benign one can recur, as Sir just said. So, yes, sir.
Dr. Maiti.
Thank you, Dr. Sumita and Dr. Saha and all the participants for a wonderful discussion on the very common problem, benign breast disease. And few points I like to comment, particularly from the last case, the phyllodes tumor. So when we are considering mastectomy, so that decision should be very crucial from the point of the patient as well as the treating doctor. Here we should consider not only the size of the lump and the microscopical part, histopathological part, but also recurrent tumor. If the phylloid tumor is recurrent, and that is very disturbing, sometimes there is once or twice recurrence, particularly young patient. In that case, we should consider mastectomy too. And when we are considering mastectomy, we should also remember most of the cases the plastic reconstruction, if facilities are available, then that is good. But if not, during mastectomy, we should do the subcutaneous mastectomy and we should preserve the nipple and areola so that there is provision of prosthetic implant in future. And but regarding the fibroadenoma, here is one situation, particularly a clean-cut clinical diagnosis of fibroadenoma when it is attained and when it is freely mobile in a young patient. The investigation FNAC, which is now considered by many as an obsolete investigation, here is the scope of FNAC is still there, I think, to me, and that FNAC will confirm that yes, you are tackling with a truly benign disease, and then instead of going for wide excision in many cases of fibroadenoma, we can go for just excision and even the enucleation. Enucleation is a very simple technique, and if we are damn sure that it is fibroadenoma, we can go for enucleation rather than excision. And regarding the granulomatous mastitis, one comment I like to make: if I am given a case of a clean-cut case of malignancy and a case of granulomatous mastitis, it is very difficult or and sometimes very embarrassing for the clinician to treat a patient with granulomatous mastitis, because regarding the outcome in case of diffuse wide granulomatous mastitis is not sure. As Professor Chatterjee, Somita has already mentioned, we should be patient we should be patient, doctor and the patient should be patient in their attitude, because it is a long drawn procedure. It may take months or sometimes years to get the better result, and sometimes as it is, there is a autoimmune component, the patient immunity may develop and we may wait that patient's own immunity along with the supportive treatment. The ultimate result, satisfactory result, will be available after 6 months, 8 months, and sometimes years. When we are treating a granulomatous mastitis, the main thing is that whether by investigation we have to prove whether it is a tuberculous mastitis or a non-tuberculous mastitis other than tuberculosis. Once it is a case of tuberculous mastitis, the management becomes very simple, and once it is non-tuberculous, then there are the problem with the outcome. Regarding the outcome, we are not sure when we will get the better result. And regarding the granulomatous mastitis, we should remember also another condition, that is actinomycosis. Though it is rare, sometimes in OPDs we get cases of actinomycosis, and if that is present, then treatment of actinomycosis is also very well defined and simple. Thank you. Very nice discussion, Somita and Dr. Saha, Professor Saha.
Milind, just one last word before we sign off. Any patient in whom of ANDI in whom you are contemplating to observe, do not observe without documenting your diagnosis. Your diagnosis has to, do not say that I think it is a benign. It has to be documented with an imaging and, as Sir said, some tissue diagnosis. It could be a FNSC here is absolutely justified. But without that, in today's era, if something happens later, you have nothing to fall back on. So yes, you can reassure the patient. Tell her that I will do few diagnoses for your peace of mind and my peace of mind. Document your findings and then observe her and reassure her. Thank you.
Thank you, ma'am.
Thank you.
Thank you, Dr. Chatterjee, Dr. Maiti, and all the students present here. Thank you.